very much. Good afternoon, everyone. I know it's been a long day, and we still have a couple of things to cover for today. I'm Dr. Cruz and Maxine Cruz. I'm a palliative care physician. I do a lot of pain as well as symptom management. I'm part of the big team that we have here at MD Anderson. So today I'm going to talk about ECD and pain management. So ECD comes with a host of other symptoms that I'm not going to be able to tackle for today, and I'm just going to concentrate on pain management. And later on, if there are any questions, please feel free to ask them at the end of the presentation. So again, just a brief background. For the most part, it affects mostly the bone. About 90% of patients have bone involvement, and then other multi-organ involvements. And so it is, because of that, about 50% of patients can present with bone pain. But again, you can have pain from other symptoms depending on the organs that are affected. So even if it's not the bony structures that are affected, you can still clinically manifest with pain. So most of, again, symptoms in terms of pain in the bones are found in the long bones, particularly the femur, so which is the arm area. You're also the leg area, as well as the humerus, which is the arm. Again, predominantly it's the extremities. You can also have bone pain, again, affecting your axial skeleton, so meaning your spine. And again, about 50% of patients who have bony involvement will manifest with pain. Now, the key again to treating pain is making a really good assessment. When you are referred to a pain clinic, typically they will have a couple of questions about where the pain is, the character of the pain is, and sometimes it's very difficult. The questions are, is it dull, achy, sharp? And so these are just some of the type of questions that people are asking, because there are a different, there's a whole different syndrome of pain. And again, sometimes the treatment would be variable, and so that's important for us to know as treating physicians what kind of pain a person is having. So we're also looking at intensity of pain, as well as, again, what our goals are. So we have such a thing as patient pain score. So for people who have been to pain clinics or symptom clinics, you might be asked, okay, so what's your pain score from 0 to 10? Most of the time, for something that is chronic, we're not able to bring down the pain to really a 0, because again, we are limited in terms of our use of medications. We can, but because of the nature of the medications that we use, most of the time, because of their side effects, you will be very drowsy, sleeping all the time. So having a pain score goal of 0 really isn't very realistic. So sometimes we talk about changing our goals to maybe something that's more tolerable, but still, pain is not really going to go away. So it's kind of a shift in perspective in terms of our assessment, of course, of your goal. And that also will, again, be reflective of how functional someone is. Because again, if we want to continue to maintain function, we want to kind of have a balance between, again, the effects of the medication and the side effects that come with it. So pain management essentially is both pharmacotherapy, meaning medications, and narcotics are one of the more frequent medications that we use, and also adjuvant techniques. Adjuvant techniques, again, you have your non-invasive. These are behavioral techniques that we use. Imagery, relaxation, acupuncture is one of them. And then sometimes we need the more invasive type of intervention, like nerve blocks, for example, for localized pain, if we don't want to use narcotics or opioids. So these are just some of them. Different management which we'll be touching on. So in terms of bone pain per se, there's very little evidence about what, in terms of targeting just bone pain. Bisphosphonates, again, it's something that we use for osteoporosis. We also, again, use it for cancer pain patients who have bone involvement. So essentially what the theory behind it is there is destruction in the bone that's causing the pain. So bisphosphonates essentially kind of help to make the bone stronger, kind of heal the bone, and so in essence decrease the pain sensation. So there's a couple of papers actually showing the use of bisphosphonates in patients with ECD. Radiation therapy, again, also decreases the pain that you experience, again, depending on the site. The issue with radiotherapy is that it's, again, very limited. It has a lot of side effects as well, and once you have irradiated that area, meaning you have treatment in specific areas, typically you cannot re-radiate at a later time. Steroids, again, because of the nature of its anti-inflammatory effect, it also helps with bone pain. And opioids, again, is the mainstay for a lot of chronic type illness that we see in patients with ECD. So pain, again, by definition, it's a sensation that we feel and we interpret. So because of that definition, it's not just all physical. So there's also like what we call a psychosocial component. So our mood also affects the way we perceive pain, the way we report pain. So let's say if we are more anxious, we probably will have more pain. And so that's where imagery and relaxation techniques come in, because we know that there is a relationship between what we feel and how we interpret it in our head. There's also, most commonly what we experience in patients with ECD, or what we see in patients with ECD, is what we call nociceptive pain. That's, again, pain that's kind of deep and achy. And it's, again, mostly, especially for solid organs, so the bone, for example, your visceral organs also. So your chest as well, your chest, your legs. Neuropathic pain is mostly pain because of nerve endings, so because of nerves. So let's say certain medications, for example, that can damage nerve endings can cause this type of pain. And usually it manifests as tingling, burning sensation, sometimes sharp pain. And this is one of the types of pain that's quite difficult to actually to treat, much more difficult than your somatic or your visceral pain. Now, breakthrough pain, again, usually you can control pain using a scheduled medication. But occasionally, let's say with activity, your pain can get worse. Again, or certain, let's say some people who have visceral pain or pain in the gut, when they eat sometimes, the pain gets worse. And so these are episodic types of pain. Psychogenic pain is, again, it's related, again, to our emotions, related to our psyche. So some type of psychogenic pain, again, there might be underlying somatic pain, but again, the way we feel, the way we think affects our reporting of pain. Oops. Can I have some help here? It just died on me.
Looks like everything is plugged in. It's tired, yeah.
Did it lose? Oh, here we go. It just lost.
The mainstay of treatment for pain, for this type of pain, is opioids or narcotics. Now, typically, when we start with narcotics, it's usually on an as-needed basis. And again, you have this whole bunch of narcotics that's available for us. So most of you have probably heard morphine, hydrocodone, tramadol, methadone, OxyContin. So there's a bunch of medications that we can try. There's really no gold standard or no right medications to start with in terms of pain. But what we do know is that if you take a look at, oh, sorry, we don't have slides. So with the WHO ladder, pain scale, pain ladder, we have at the bottom, when you have mild pain, we start with what we call NSAIDs. We start with your ibuprofen, your Advil. And when that does not control pain, we go to a higher tier, a more potent type of medication. And that's your kind of your weak opioids or your weak narcotics. And that would include your tramadol, your codeine. And then when that also does not work, when the pain is very severe, despite those types of medications in use, then you go to a stronger family of narcotics. So you have your morphine, your dilaudid, your methadone. Again, like I said, when you start medications, your doctor wouldn't know how much to start you with. And again, these medications, it is a double-edged sword. They're good, but at the same time, they carry serious side effects. And so they start with very low doses, and they also start as an as needed. And depending on how much a person would require to be comfortable over a 24-hour period, if the dose is really small and it doesn't make kind of any sense for them to do a scheduled dose, then you will continue to be on an as-needed basis. However, if, for example, your need is high enough that would warrant, because you're having a lot of pain in between the medications, then it might make more sense that you are on a what we call scheduled regimen, or something that typically it's every 8 hours, or long-acting medications. And again, we have a bunch of choices in terms of these medications. Occasionally, besides opioids, we might require some adjuvant medications. Again, adjuvant medications are non-narcotic medications that kind of help alleviating the pain and at the same time decreasing your requirements for narcotics. Now, if we have, let's say, neuropathic pain together with your somatic pain, we can do what we call adjuvant for neuropathy. You've seen possibly the commercials for Lyrica, so that's pregabalin, gabapentin or Neurontin. They're very good for neuropathic pain. So you can start that together with your opioids to control the pain that you might have. Your doctors might start that together with your narcotics. Steroids, like I said, is also an adjuvant medication that can be added to the regimen. Occasionally, we also add on NSAIDs even when your opioids are stronger, just because of that anti-inflammatory effect that is still very useful for patients who are having pain. In terms of side effects of opioids, the more common side effects is constipation. So if you are started on pain medication, automatically you need to be started on a laxative. So there's no as-needed laxative because we know that you're going to get constipated. 99% of patients who are on narcotics will get constipated. So there's no question. You have to start on a laxative. You might also need to be started on an anti-nausea medication. Again, about 95% of patients who are put on narcotics, whether it's an as-needed narcotic or a scheduled narcotic, will get nausea as well. So you want to prevent it from happening, because constipation and nausea also result in decrease in your appetite, and it also can contribute to pain, particularly back pain. And we see that in a lot of our patients who really challenge the idea of having to take a laxative with their narcotic. Other side effects, again, commonly would be drowsiness. So 100% of patients, of course, will have drowsiness, especially when you're what we call opioid naive. So when you're starting a pain medication, you will feel drowsy. But you will develop tolerance to this drowsiness. So after about 2 or 3 days, I'm kind of lost right now. Okay, I don't want to go back to where. Okay, so this is just, again, part of the pain ladder that I was talking to you about. So at the bottom you have your non-opioids, so your aspirin and your NSAIDs. And then in the second tier you have your mild opioids. And the third step would be your stronger opioids. Okay, so again, this is what we talked about earlier. So these are just some of the examples of your strong opioids. So it used to be early in the year, hydrocodone was still a weak opioid, but now it is considered a strong opioid. So it means that it needs triplicate. It needs a special script for your doctors to be able to prescribe them to you. So they are controlled substances. Again, they're just in this table, you can see different formulations of the medications. And they can also be given, some of them can be given both IV and what we call subcutaneously, meaning under the skin. Fentanyl is the only medication really that comes in a patch. So this is useful for a lot of patients who, for example, are nauseated or are not able to really use the gut. So this is just the NCCN guidelines for adult cancer pain that I had mentioned earlier. You typically start, so opioid naive patients, those are patients who have never been exposed to narcotics in the past. So again, you use it as, you give your narcotics on an as needed first, and once you kind of established how much they would require in a 24-hour period, then you can start the patient on a scheduled regimen. So for opioid tolerant patients, again, you just take a look at how much they have required, both in scheduled type medications and as needed medications, and from there you kind of just do the math to kind of titrate so that you achieve the comfort that you and your patient feel that is a good balance that for function as well as side effects. So again, like I said earlier, opioid is still the class of drugs for management at this time. So this is what we were talking about, opioid-induced neurotoxicity. This is part of the side effects. And these are the more serious side effects that we see with opioids besides the drowsiness, the constipation that I had mentioned earlier, and the nausea. So when you talk about opioid side effects, again, the background is your narcotics work on your brain. It's similar to, they attach, the active metabolites attach to the same receptors in the brain where alcohol attaches, where heroin attaches. That's why sometimes we might feel good about it. About taking narcotics. And so that's why, again, when you have toxic doses of narcotics, you can get these side effects. So you can get excessive sedation. So it's not just the sleepiness, but it's excessive sedation means it's very difficult for you to be aroused. Shaking or rigorous shaking is what it takes for you to kind of wake up a little bit. Hallucinations, again, seeing things or hearing things that are not there. Confusion, just not being cognitively present. You may be talking in gibberish or talking tangentially. Myoclonus, again, these are just jerking movements, something that you can't control. So jerking muscular movements, and of course seizure. But again, what you do see when you talk about opioid-induced neurotoxicity, you see excessive sedation first before you actually get myoclonus and seizures. And also, I forgot to add on to this slide, it's not part of opioid-induced neurotoxicity, but another side effect that we also watch out for with excessive narcotic is respiratory depression. So especially in combination with other medications, like your benzodiazepines. So benzodiazepines, these are anti-anxiety medications. So your Ativan or lorazepam, your Xanax. So again, certain combinations with your narcotics can potentiate these side effects. So your doctor would really need to be careful, and your doctor would know what types of medications you're on. Okay. Now, when you develop that type of toxicity to narcotics, you can do what we call an opioid rotation, meaning it's just an opioid switch. You switch from, let's say, morphine to hydrocodone or hydromorphone. So you just switch a different type of narcotic. And what it does is you allow that old medication that you have to kind of wash off of your system. You don't want to completely take them out because, one, people can go into withdrawal, and two, you'll also have, again, the pain that you're trying to treat. Dose reduction, again, you just kind of go down on the dose. And hydration, because sometimes these metabolites, the active metabolites and are excreted by the kidneys. And this is typical of, let's say, your morphine and OxyContin and your hydromorphone. So if you are dehydrated, those metabolites can stay in your system longer. That's why you're getting toxic, even if you have been on the same dose for many days or many months even. Now, if you also have what we call delirium, which is, again, that confusional state where you have agitation secondary to toxicity of the medication, besides doing all those rotation and reducing the dose, you might also want to treat the psychotic symptom or that agitation, sometimes with neuroleptics or antipsychotics, such as haloperidol or Seroquel or chlorpromazine. But again, those are just the more serious, what you call this, side effect of opioid toxicity. So just like what we talked about, opioid rotation is just changing from one narcotic to another. Again, there's a mathematical formula for this. So when they change it, you're not going to be receiving less of the medication or less of the pain medication. There is an equivalent dose. So the same thing, if you have uncontrolled pain, you also might need to be switched to a different medication. So in the same way that people prefer Diet Coke over Diet Pepsi, your body might also metabolize narcotics in a different way. So currently we are doing some testing as well about the genetic basis of how we respond to these medications. Again, it might be a metabolism issue. So sometimes when patients say, oh, I don't know, morphine doesn't work for me, but hydrocodone does. Even when you know that morphine is a stronger medication, so kind of doesn't make any sense. But again, it might be related to metabolism. So neuropathic pain, like I touched on earlier, you can have a variety of ways to treat it. One of the older medications that we use are what we call tricyclic antidepressants, and these are your amitriptylines and nortriptylines. These are old types of medication. We have good experience with it. The problem with them, though, is that they have a lot of drug interactions. So again, for your treating physician, they need to know what you're on so that you don't kind of potentiate the side effects that come with these medications. Anticonvulsants, initially, like I said, gabapentin or Neurontin. It's one of the older drugs that we use, also very effective and also cheap. Clonidine, steroids. Problem with steroids, though, is that we can't really use it for prolonged periods of time because, again, of the side effect profile that we see with it. You can also use local anesthetics. For neuropathic pain, again, you have newer agents. So you have Cymbalta or duloxetine. So it is an antidepressant, but we're seeing that, again, from research that is very useful for patients with neuropathy. So if patients also have like some mood issues, so instead of doing 2 drugs, your doctor might say, you know what, let's do Cymbalta because we're hitting 2 birds with 1 stone. And it also helps with sleep. So 3 birds with 1 stone. And then Lyrica or pregabalin as well is another choice. So like I said, also non-pharmacologic methods, again, because of that psychological and psychosocial component of pain that we experience, these things like biofeedback, music therapy, relaxation, that kind of also helps not in isolation to your medical therapy, but to help decrease your requirement for narcotics and for other medications. And so when you decrease those, then you also potentially decrease the possible side effects that can occur and possible interactions of medications that can occur. And that is the end of my talk. Anybody have any questions? And again, sorry about the cut in the slides earlier. Yes, ma'am. Right. Right. The mechanism. Well, Right. So there were two studies that actually showed that bisphosphonates helped with some bone pain, and they were specifically for ECD patients. So I was surprised as you are, because again, it's not really for lytic bone lesions, although there is, I think, a percentage of patients who have both sclerotic and lytic lesions in ECD. It wasn't mentioned in the study whether it was only for lytic bone lesions. It just said bone lesions in general. So bisphosphonates is something that you can use, but like I said earlier, there's not a lot of study focusing on ECD itself. And so I would do narcotics, again, for chronic type pain. Thank you.